Welcome to the Masterclass 3, Cool and Collected Pulmonary Artery Denervation, co-sponsored by the Society of Cardiac Robotic Navigation and Stereotaxis. Good morning to all of you participating, and thank you for joining us for this educational event, again with a very unique topic. Our chairs, Professor Sabine Ernst and Dr. Tamas Tsilitorok, will tell you more in just a few moments. During these masterclasses, we encourage you to contribute as much as you like with your observations, questions, and remarks. Please note that making recordings or screen captures during this event is prohibited by the audience. Also, we kindly inform you that physicians may discuss or present information on products, product claims, or techniques that may not have approval or clearance in all geographies. Prior to using devices, please review the instruction for use for a complete listing of indications, contraindications, warnings, precautions, and potential adverse events. Kindly note that presentations or discussions may feature products that are not manufactured or distributed by Stereotaxis. To fully benefit of the Masterclass 3, Cool and Collected Pulmonary Artery Denervation, we ask you, our audience, to actively participate in the event. Please use the chat function in the Zoom control panel to pose questions or remarks that you would like to be discussed in front of the audience. Our moderators will ask these questions at an appropriate time in the procedure. For questions you would like to be answered by the panel in writing and does not require to be part of the discussions, please use the Q&A function. Our chairpersons will reply to you in writing. Should you drop off from this event, you can always get back in using the same link. It is now with great pleasure that I welcome Dr. Tamas Tsilitorok, cardiologist, electrophysiologist, and clinical head of cardiology and electrophysiology at the Erasmus Medical Center of Rotterdam, and main organizer of Masterclass series, also board member of the SCRN Global. Dr. Tamas Tsilitorok.
Good morning, everybody, and thanks for this kind introduction. It is also from my side, it's a pleasure to welcome you this morning. And before we start with this unique case presentation, I would like to tell you a few words about this masterclass series. And first of all, I would like to introduce Sabine. We actually don't have to be introduced because everybody knows her. And after me, she will talk a few minutes as well. But the reason why I started is not because we are impolite, but this masterclass series was created by us, and then I would like to actually do make a short summary about the previous master classes, and also to tell you and tell to the audience, especially for the ones who are new today, what is the idea behind these master classes. So cardiac robotic navigation actually was started in Europe in a few centers, including the center where Sabine works, and it has not yet, but almost 20 years of history. And we must say we had ups and downs. So during these years, cardiac robotic navigation, especially in electrophysiology, achieved a lot, and we have a very significant strength. So part of this masterclass series are made to show these new possibilities and also to show you cases when robotic navigation, I think I can say without exaggeration, outclasses manual ablations. On the other hand, there is still a lot of negative misperceptions about robotic navigation, and that we would like to address as well. So in a very first one, I addressed one of these misperceptions by treating many patients within one workday, because one of the misperception regarding this technique, the Stereotaxis ablation technique, is that it's actually slow. So we proved that it is not slow. It improved enormously, and we can beat manual ablations if we want. And the other things, to show you unique things, that was the idea with the second and this third, but Sabine will introduce this in more in detail, because there are new hardwares available, and that was the part of the second masterclass event when we showed to you guys the new Genesis system. And here comes something which is unique, but it's unique medically. And at this point, again, I'm very happy that we go forward, and I'm very happy that together with Sabine, we are kind of organizing committee for the master classes. And I give you the word to introduce this actual event today.
Thank you, Tamas. And also warm welcome from me. I'm, as you have heard, I'm one of the kind of pioneers. I don't feel so old, but actually I've used the system now for 18 years, and I'm very, very happy to see that it has come such a far way. We have seen so much improvement, as you've heard already. And today is a special day because so far we've always talked about cardiac ablation to treat arrhythmias. And I think it's a really good thing to start thinking a little bit beyond the myocardial tissue and think of what else can we do. And part of why I got interested in catheter ablation of the autonomic nervous system was that I thought, okay, we need to really find out why things are happening. We had learned that pulmonary vein isolation had actually helped us to isolate the trigger, but for AF ablation, but we didn't really know why the trigger was firing in the first place. And that started the whole idea of thinking, what else is there to the heart than myocardial tissue? Now, there's a lot beyond that. The whole autonomic nervous system is beyond that and helps regulating the heart. The heart is essentially able to maintain rate and contraction, even if all the central input from the brain is severed off. We know that from transplantation. So that was the first step to say, okay, maybe there's something else. Maybe we need to target this. And you've all heard over the years about the fantastic results, and then maybe some sobering up of renal denervation impacting on the heart. And there's so much more that the heart is connected to. Now, pulmonary arteries are also highly autonomically innervated, and that's where this novel way of treating pulmonary hypertension comes from. It's actually a technique that has been introduced a couple of years ago, mostly experimental. People ablating in the pulmonary arteries and trying to reach the epicardial ganglionated plexi. It's pretty much the same as we tried in AF ablation, and we see, there's some believers, amongst the believers, I can say right away. And the same thing here is true for pulmonary arteries. There have been some experimental initially, but also clinical evidence. So I'm extremely thrilled that the group in Novosibirsk have actually taken on this task and used the system in applying a denervation to ganglionated plexi around the pulmonary artery to treat pulmonary hypertension. The concept is pretty straightforward if you think about it. Reaching this place, of course, as nearly everything that we do is not absolutely impossible to do manually, but magnetic navigation makes it such an elegant and easy way. And I'm sure the cases that we're going to see today from Novosibirsk will be fantastic. So maybe I could ask for the next slide to introduce Alexander a bit more. Alexander Romanov, I think, is for at least 10 years, that's my recollection, at Novosibirsk, has worked with Yevgeny Pokushalov there for a long time. We have been interested both in the ganglionated plexi for a long time. And I also know that they are very active magnetic centers. So I think that brings them together in looking like a kind of perfect starting site for this kind of trial. So I believe I can hand over to Alexander already. We had a connection to him. That's the Meshalkin National Medical Center. And I hope that they can hear us. And our connection.
Hello, do you hear me?
Yes, we can. Good morning, Alexander.
Good morning, good day. So welcome. We're very welcome you in our lab, in our city, Maybe you don't see the snow outside, but this is our actually friendly team with our senior electrophysiologist Vitaly. And now you see the 4 musketeers. Okay, so Vladimir, he is the head of anesthesiologist department, and another Vladimir is our fellow, and he will support this procedure today. And also we have 3 ladies who will help us in terms of operation procedure, anesthesiologist support, and technical support. So I think now we will start with the case presentation and start the procedure, okay? So please, can we see the slides? Okay, so please, next slide. So the first case, we have a 56-year-old lady with idiopathic pulmonary hypertension. Her complaints are dyspnea during minimal or daily physical activity with some signs of fatigue and weakness, and also some kind of palpitation. So the symptoms started since 2017. And based on the echo data, she had at that time tricuspid regurgitation 2 or 3 grade with moderate and systolic pulmonary pressure of 100 and more than 120 mercury. So based on the CT data, there were signs of pulmonary hypertension. So at admission to our clinic, she was in NIHA 3rd functional class, and you can see the echo data. So she has a pulmonary pressure of 98 mercury with mean pulmonary pressure of 47 mercury. Also, the right ventricle fractional area covering is around 33%, so it's like a right ventricle injection fraction, and the same tricuspid insufficiency. So the angio of the pulmonary arteries was performed 1.5 months ago, and you can see approximately the same story regarding the high pulmonary artery pressure and systolic and mean and diastolic pulmonary artery pressure. Also the high pulmonary vascular resistance of 826. So she also has some signs of chronic thrombus in the left pulmonary artery based on CT. So she took sildenafil before admission to our clinic during 1 or 2 years, and then she was switched to Resiguat. Also, she take all modern heart failure therapy and warfarin as an oral anticoagulation. But unfortunately, the pulmonary artery pressure and the hypertension still exist. So she was consulting with our surgeon, and nothing to do with this thrombus. And actually, I will show in a minute how it looks like. So next slide, please. So you can see the angio, you can see the right ventricular outflow tract and the right pulmonary artery in the left picture of this slide, rather big one. And on the right picture of the slide, you can see the left pulmonary artery. Next slide, please. And this is how the CT scan looks like. You can see some part of the right ventricle, also outflow tract, and the big right pulmonary artery, and also the left pulmonary artery with some kind of defect. It means that it should be thrombus somewhere. So we perform the measurement and we can try to use, we can try to perform the pulmonary denervation in this case, because the distance to this, let's say, thrombus is around 2 centimeters from the bifurcation to the left main pulmonary artery. So this is regarding the case, and we are now going to the lab, and maybe I will give some words to our anesthesiologist Vladimir to comment on the current pulmonary pressure and all the parameters that we have now. And can we now see the main screen from the control room?
Yes,
Yes,
Yes, we can.
you see. And Vladimir, please comment. You can take a mouse and comment on this line. And can we switch on the microphone of Vladimir, please?
Colleagues, do you hear me?
we hear you.
Good morning, dear colleagues. I want to say a few comments about our patient, about anesthesia. Our patient is under the moderate sedation. You can what we have done to this moment. We perform a jugular vein catheterization, inserted a Swan-Ganz catheter, and you can see on our monitor all the parameters what we have: the arterial pressure, the pulmonary pressure, which is high, and the saturations level. This patient is very low at baseline. Now she is on the oxygen about 5 liters per minute. And we are ready to perform, to measure a cardiac output. We made the first measurement, and you can see the cardiac output is about 3 liters cardiac index. You can see there on the right on the screen.
So what we will do next? So we will do the control measurements of the pulmonary parameters, and now we need to put the Swan-Ganz catheter again to the right pulmonary artery, because the pressure is quite high, and the Swan-Ganz catheter always moving back from the right ventricular outflow tract to the right ventricle. So we ask to have a big fluoro screen. Big fluoro screen. Yes. Can we see big fluoro screen? No. Fluoro screen. Yes. And can we change it? So now you see how the catheter goes, moves in the right ventricular outflow tract, and we try to put it. So it's rather tricky, because we of course try to manipulate with the when we let's say open the balloon, inflate the balloon, because for safety reasons we don't want to have some perforation, let's say, for that. And we're now trying to put the catheter to the right ventricular outflow tract, because once again it's not easy in such pulmonary pressure. So the thing is that
Alexander, can I ask you something?
Yes, please.
Because it's already very, very interesting to see this. I hope you won't be angry if I cause struggle. So that clearly shows how difficult to place sometimes these catheters in these kind of pressures, and that leads us also to the actually to the robotic part. And during this manipulation, it would be really nice if you tell your all of your own motivation to do this with stereotaxis. And also it would be nice if you just tell a few words for the audience about your previous experience, what kind of procedures you still prefer to do manually, what kind of procedures you do mostly with the robotic, to get a picture about your center.
Yeah, so I mean, of course, in some procedures in the frame of clinical trials, for example, here we do some like unusual procedure for pulmonary denervation, and also with a with another option. For example, we do 2 cases with the renal denervation with the stereotaxis. In general, we use it for patients with atrial fibrillation ablation, but especially in patients with a big left atrium. And also we use, of course, this system for VT ablation and also with epicardial VT ablation. And what else? We also use it in children, especially after correction of the congenital heart disease, because it's rather tricky because of due to complex anatomy. And in these particular cases, robotic system is a unique opportunity, because sometimes you don't have option manually to perform some, let's say, part of the procedure and to do the ablation and to reach the heart chambers. So I would say for the VT ablation, for the patient with congenital heart disease, and for such unique procedure, the robotic system is quite useful. And of course, our main flow is patient with AF, and the patient with a big left atrium is also unique opportunity to do the safety and effective procedure. So we insert the catheter to the. So I will change the projection from the aereo to eleo. So by the way, for the right pulmonary artery, we use aereo projection. For the left we use eleo. You can see in eleo projection the catheter again goes back and to the right ventricle, and now we're once again trying to put the catheter again to the left main artery, so somewhere here, because you see how the catheter is moving, because so I think this fine to put this here. Okay, so here the catheter you can see in the left pulmonary artery, and okay, so now we can switch to the monitor. We have a preset of the monitor, anesthesiologist monitor, to see the measurements, and once again you can see in the fluoro that the catheter is moving. So so now you can see the monitor once again, and we will try to measure the pressure in this case. You can see it's quite challenging. And that is why manually it's almost impossible to manipulate with regular catheter, because the pressure, the pulmonary pressure, is almost equal to the systemic pressure, let's say. Yes, we have you can see some challenging.
How many cases you did so far?
So
in total?
Total we've done for all category of patients, we've done 32 cases. I mean, 32 cases in the frame of clinical studies with different patient group. So now we are reaching left pulmonary artery, and you can see that the pressure in the left pulmonary artery is now, the systolic is 91, and you can see that the mean around 60. Yes. So now we perform measurements.
Yes.
Yes, and Vladimir will do it. And you can see the curve. The yellow curve is corresponding to the pulmonary pressure.
Can you enlarge this screen because I'm not sure that everyone. Yeah, very nice. Thank you.
Okay, just 1 second. I will check it. Okay, yes, you can see the measurements nicely, and we will try to looking forward for.
We will do 3 measurements.
So yes, Vladimir will comment on, please.
We will do 3 measurements to take a medium measure, and then we made all the measurements of pulmonary pressure and resistance.
And also, once again, I want to underline that this patient has a moderate tricuspid insufficiency, and also this is a point how it's not easy to put just a one-hand catheter, because actually we are not started yet the main procedure. And when during let's say Vladimir measurements of the pulmonary circulation parameters, I will give some comment what will be the next step of the procedure. The next step will be the following. So we have a steerable sheath. We use Agilis sheath for that, but unfortunately in Russia we do not have Visigo. Not yet registered, but you can use any steerable sheath for that because it's very important. So we will use pigtail catheter to have a support to put the Agilis sheath to the right ventricular outflow tract. And if after that we put the ablation catheter to this, let's say, sheath. Because you cannot position the sheath in the right ventricular outflow tract with guide wire only, because you see that this one-hand catheter is moving back and forward due to high pulmonary pressure, and it will be impossible to put the guide wire somewhere in the pulmonary artery branches. So we need some kind of support for that. In some very, very complex things, we use a additional steerable support with maybe some steerable catheter, just to position the sheath in the correct place to perform the main stage of the procedure. So now the
one more
measurement, the final measurement, yes?
Because difference between previous measurements.
Yes, so we have a difference. We want to be sure, and actually at the end of the procedure, we again will do the measurements, and of course we will try to position the catheter in the same fashion like you see on the fluoro screen. Of course, it's some, let's say, discussable part that maybe we cannot put this one-hand catheter in the same position like before, but we will try to put in the same spot. But at least it will be in the pulmonary artery, the main pulmonary artery, or left main artery. So the final measurements, and then we will introduce the sheath to the right ventricular outflow tract. So, Vladimir, can you comment what are you doing now?
Yes, so we can see the all needed parameters. The cardiac index of this patient is 2 liters per minute, and on the monitor you can see the Pulmonary vascular resistance, it's about 1046, and the systemic vascular resistance is 1046. Yes.
So this is some abbreviation in Russia, but you can see that the peripheral vascular resistance, I think the key parameters for pulmonary circulation, for pulmonary, let's say, distal involvement of the pulmonary branches is the pulmonary vascular resistance, and this parameters is 1046 Dn per centimeters. Yeah.
Yes.
So we do the final measurements, and then can we have a big fluoro screen once again, please? Just a second. We will have a big screen, yes, and we will try to put the pigtail catheter into the right ventricle. So you can see the Achilles sheath, and it's a little bit tricky. Yes. So once again, so tricuspid insufficiency and some tricky part to move the catheter in. So we try to, now we pass the tricuspid valve, and then we try to put the guide wire, you can see in the right ventricular outflow tract, and it goes, I think, to the right pulmonary artery, one of the branch of the right pulmonary artery, and then you can see that we are now trying to go forward with the Achilles sheath, and actually it looks pretty good. Okay, once again, let's check in a LAO projection. Yes, now we're in the LAO, but I think we need to a little bit go back with Achilles, because we need to have a distance to manipulate with the swan with the ablation catheter. So once again, check with the aerial to see where we are. So it's not bad. So we remove the pigtail catheter, and just one correction. You can see. Yes, I think we leave the Achilles sheath somewhere there. Then we will do the flushing. I will check. Okay. So this is actually the main first part of the procedure. So do you have a comment or question?
There are no questions from the audience so far. You, Sabine?
Yeah, I just wonder, you know, this, I mean, the Achilles is pretty stiff sheath, so I'm always cautious in that area, because that right ventricular outflow tract area is pretty thin, right? Are you?
Yeah. Yes,
are you
but
scared for preparation here, or?
No, I mean, you know, it's a good question, and that is why we use a pigtail catheter, just to be sure regarding the safety. Of course, we can use sometimes the preface, like a regular multi-purpose preface catheter. It's possible to use. It's more, let's say, gently, but I mean, in this particular case, we preferably prefer to use steerable sheets for that. Unfortunately, in Russia, we do not have opportunity to use another steerable sheet for this kind of procedure. So now we are almost ready. So we are now open the catheter, ablation catheter, and we will put the catheter, then position the magnets, and I will go to the control room, and we will start the main part of the procedure.
Alexander, we have a question in the meantime, and actually I wanted to ask the same question. It is in line with the question of Sabine. Can you use actually the ablation catheter itself to go into the pulmonary artery and then following it by the agilis?
But
instead of a pigtail, you would do this part already with the ablation catheter, with a magnetic catheter.
I mean, you know, we also tried to do it, but of course, the ablation catheter is rather soft, and sometimes, in many cases, it's very challenging to forward the agilis sheath into the right ventricular outflow tract. So, I mean, for example, you can definitely reach with the catheter the pulmonary artery, no problem. But you cannot advance the agilis sheath because the catheter is so soft, and you do not have support, and the catheter will make a loop for that. And that is why we use something, let's say, something tough to have a support, just to put the agilis in the correct position. This is like a point. But I mean, for the patient with not so high pulmonary pressure, you can try to do it. But you see, in this particular case, we, let's say, had some challenging to put this one hand catheter because I think it's also so soft and move back and forward very fast. But with to advance the agilis sheath and to advance the pigtail catheter, we did not have, let's say, big problem. Now you can see.
Thank you.
Yes, now you can see, I think, the main screen. We also prepare the CT scan. CT scan, you can see it in the carto screen. We create the geometry manually because, I mean, in let's say automatic segmentation, we cannot receive a good relationship between the bifurcation of the pulmonary arteries, and we in advance create the CT scan. Of course, I mean, in this particular case, we will not plan to use the contrast because the patient has kidney disease, and she already undergone the angio, and we do not use the contrast in this particular case. Just
can you superimpose? Sorry to interrupt you. Can you superimpose on the stereotaxis screen on the Odyssey the scans that you have?
Sabine, can you repeat once again?
You said you had a CT scan, so that was one contrast exposure, and you have the contrast that the angiogram that you just made, right? So I wonder if you could overlay the images on the stereotaxis.
Images of you mean images of the angio?
Yeah, or the CT scan, it doesn't matter. So people have a bit of an idea where the sheath is now in comparison to the valve.
Unfortunately, I think unfortunately maybe in our version we cannot do it. But of course it will be a useful tool. But I will show that I use in daily practice I mean, what position of the of the fluoro I use regularly for our regular procedure and as well as for this procedure. So I use oblique projection. I will show in a minute. So now, just
maybe you can show us the lab once more. I think the people who are not that familiar with how the system is hooked up.
Yeah.
Insert the catheter and then how the cardio drive is connected.
So, can we show fluoro once again? So I will try to put the catheter in.
So the nice thing about this magnetic catheter is that it's very, very soft.
Yes, very, very soft, and actually it's, I mean, it's very nice for the safety issue. I mean, if he has some obstacles, he making a loop, and the risk of perforation is quite low. So can we have a big screen once again, please? Yes, thank you. So I will try to prepare the LAO projection that I will use in the main step of procedure, and area projection also. Area is quite okay. So
it's all about isocentering the table so that the region of interest is actually really in the tape in the middle before the magnets come in, right? That's what you're doing.
yes, so I do some short, very short imaging and oblique projection just to be sure that to use during the procedure. So I made the imaging, short imaging of the in area projection, and do the same in LAO just to see the position of the catheter, and I will show you in a minute how it looks like. Can we fix the video? Yes, we do it. And then the final part of the procedure, we are trying to find all dots in place. Just once again.
At the moment we have 4 dots, 4 black dots on the X-ray.
Yeah, so we're making it 6.
So I might explain that. The 6 dots that you see are on the location pad of the Carter system. That's the electroanatomical mapping system that we so usually take for EP ablations. And that allows to register the Carter system to the X-ray and then to the stereotaxis system. So that's kind of a vital step to register everything together.
And actually, we are now ready to move the magnets, and maybe we will ask the Konstantin, our technical support, to have a picture from the lab. Konstantin, can you switch to the camera which is located in the operation room?
And maybe you also point out the cardio drive and how you connected that to the catheter.
Yes, I will make some comment on that.
Okay, we're in the lab.
So now you see the catheter. Yes, you can see the Agilis catheter. So we insert the magnetic catheter through the cardio drive. This is actually like a motor that will move the catheter. So this is actually our final view of the Agilis sheath and the magnetic catheter. and of course it's irrigated. And now we are move the magnets.
You can, don't show us a close-up anymore, just zoom out a bit so we can see the whole lab again, see the magnets.
Zoom out, please.
Okay.
And you can see the movement of the magnets, and the magnets will automatically stop. And now we will see that the magnets are in the navigate position. So this is how they looks like the preparation for the procedure. I mean the first stage of this procedure. Actually, the most tricky one, be honestly, because you see that for us it was rather tricky to put the Swan-Hans catheter due to high pulmonary hypertension, and now we are switching to the control room. And can we have a main screen from the control room?
Perfect. Alexander, let me just ask a quick question. You said the patient is sedated. How deep is the sedation? Is she spontaneously breathing, or do you have a masking, or how much using propofol? What's
yes, she is breathing, and Vladimir. I will ask Vladimir because he. So we use a propofol and fentanyl. The propofol infusion in 10 milliliters per hour. It's let's say constant sedation. I think this is a consciousness sedation with analgesia. So propofol and fentanyl.
Okay, but she's spontaneously breathing. Okay, fantastic.
Yes, sure. Yeah, sure. So now we can see the screen. So with the main screen, and now we need to register our catheter.
Fantastic, and you can take your LED off, right? So that's the nice advantage of having to sit outside. It's awesome.
He didn't do it yet, but he can.
Yes, but we can. So once again, I will switch. Not receiving information from the position catheter. What we have? So we have some issue with the catheter. It's connected, but I think fluoroscopy position is in not permitted range, but I think we need to, so we have 6 dots, but I'm not, I will check in the lab. Maybe we need to a little bit play with the fluoro tube. Yes, and now I think it should be resolved.
So this part is for the stereotaxis users. It's very obvious what he is doing. For the non-users, just again repeating what Sabine told you, it's a registration process that the electroanatomical mapping system is registered into the fluoro system. And mostly it's straightforward, but sometimes we have some technical issues, and Alexander is solving them at the moment.
Yes, because we have some technical issues there. Our tube was a little bit, let's say, the tube or the fluoro tube was near the patient, and I just move it up, and we solved it. So I will try to have a LAO projection and the RAO projection in this screen. You can see it in this particular screen in the left part. So what we do now? Now we will try, we need to have a breathing test, because let's say correction for the breathing when we perform the mapping of the pulmonary artery trunk, and this we regularly do with the navigation system. So now I will also.
Sorry, Alexander. Can I just quickly interrupt you and say, just maybe also as an introduction to non-stereotaxis users, the way that you set up your screen on Odyssey is pretty nice, because you can see, of course, the Catheter system. That's the right lower corner. You can see ECGs, always good. You know, see your hemodynamic things and your X-ray. But you also have here where you just loaded the RAO and LAO and the reference images. I think, can you point that out, and the map catheter that you can see in real time there, because that's, I think, one of the nice features is the picture-in-picture display. So I'm sure you will not X-ray much anymore because you see where the catheters are actually, right? Can you point those two views out again? And the map that you can see there?
Yes, so now I trying to make some testing correction for breathing, and because we need to start with that to register the catheter. And as Sabina said, so this is our, let's say, setup for the regular position, a regular procedure. We have an ECG, we have all the measurements, all the hemodynamic things. Unfortunately, in these patients particularly, sometimes it's quite, I mean, not so easy to perform the breathing test due to some technical issue, because the catheter, you can see, it's need to be moving. We ask the patient to breathe, maybe to have some breathes a little bit more deeply, just to register the catheter. So yes, now it's fine. The catheter is okay. You can see the curve of the breathing. So what we will do next? So what we have on the screen, on the left upper corner, there is a fluoro screen, but as Sabina said, we not plan to use fluoro, maybe in some, let's say, urgent case. And this, you can see my back and my head. So in
your
the
leg still
screen.
for you. Take your leg off.
Yes. Yes, and actually in the left part of the screen you can see the LAO and RAO projection, because I've made some imaging before that. We also have the stereotaxis, the robotic screen, which integrated with navigation system. In this case, it's a CARTO. And as I said, the hemodynamic screen and ECG screen. So now we are starting to map the pulmonary artery and right ventricle. So we do the correction for the breathing. So we exclude respiratory data, and we are ready to create the map of the pulmonary artery. So I will a little bit zoom out. So, I mean, regularly we use setup of 10 or 12 for the regular procedure, but in this case, we can map it precisely. As I said, we also have a CT scan, and we can also, of course, merge it a little bit later on when I map a bit. And we will try to merge with CT and do the merging and to see how the anatomy looks like. You can also see in the fluoro screen our mapping, how the mapping catheter is moving.
Alexander, yes. In the meantime, we have again a question from Pedram, who is one of our board members, by the way. Do you have to place the CARTO patches differently, higher because of the higher location?
No, in this particular case, no. For example, as I mentioned, we do a couple of cases for the renal denervation, and of course we need to put the patches in the particular area. But in this case, because, for example, you know, we perform procedures for the right ventricular outflow tract, PVC, for example, ablation, and I think it's maybe not it's not crucial to change the patches location. So.
And I have myself another question. I see that you are moving very nicely, and the map is shaping up. I don't use too many automatic features when I use the stereotaxis, but actually in blood vessels, I do use it. And can you comment on this? Whether you use this?
Yes, actually, the system has automatic features for the mapping, but we don't use it in our regular practice. I mean, I saw that Thomas use it, for example, rotation when he do. If I'm correct, when you do the masterclass for fib ablation, you use correction. You use the rotation, circular rotation of the catheter during the map. So,
yes. When I'm in a blood vessel, that's why I asked whether it's useful for the pulmonary artery, or you never use that.
Actually, in a regular practice, I do not use it because I don't know. It's possible to use, no problem, but I prefer to use, let's say, to create the picture manually.
Can I just make a quick comment? Just because you just dropped into the right ventricle, it's kind of nice to see everything, of course, and you could see just now that you had a big ventricular signal on your map.
Yeah.
And you just dropped into the RV. So it's nice to see the image integration on the left part, just below where your head is, essentially on those two screens, and one is REO, one is LAO. And it's kind of nice, of course, for us to also see the signals. So that's the bottom one on the Carter screen. Now, probably most of you have noticed that there's quite a lot of noise when the magnets move. That's, of course, if you have a conductor and you move the magnetic field, then you induce a small current. As soon as the magnets stop, that current goes away and you have a clear ECG again. So I think this is just for people who started getting worried about any other arrhythmia here. And that's probably also a point. I think we have some very experienced Carter users here. I think we are stereotaxis users here. We're all very little. At this point, I'm not worried at all about perforation or anything, because I know the catheter is so soft that it won't be able to do that. So you're freely moving. It's nice to see how you're moving the magnet, and the catheter follows it and goes parallel to that. So that's a very nice kind of show of how the magnetic catheter is actually used and moves around.
Sabina, you're absolutely right. When we start using the system, of course, we also was a little bit conscious regarding this ECG, let's say, far field, and sometimes especially when you perform the ablation of VT, so you can recognize that something wrong, that happens something wrong. But of course, this ECG, let's say, ECG problem, temporary problem concerning only the movement of the catheter, when you move the catheter. And when it's stable, so you are quite, you see the quite good signal. So now the picture may be not so elegant, but I'm trying to, let's say, gently manipulate with the catheter, because as I said, the thrombus should be in the left main arteries, somewhere in the main left, and I don't want to push too much and try to map it correctly. So now I will try to create outflow tract a bit more, and then maybe try to merge it with a CT scan, just to understand where I am and what need to create more. And after that, I think we can altogether design the line for the further ablation. So now once again,
yeah, just to express again how you steer. So you're grabbing with your mouse this yellow vector, and then you turn it to the direction that you intend the tip of the catheter to go to. And then this green vector starts moving, right? So the green is actually the one that you're planning, and the yellow is the actual field direction. And the forward backward is with this little motor drive that is shown in the cath lab. So that is basically a mechanical movement.
Yes, and actually you can also choose in which distance you can move the catheter. So in our practice, when we map, so for regular procedures, so I use 5 millimeters for moving catheter just to collect points rather fast, 5 or 6. In this case, I use 3 just to create the map maybe more precisely. And actually, the vector is the vector corresponds the rotation of my catheter. So if we comparing with the hands, so I rotate clockwise or counterclockwise, and with the mouse I move the catheter back and forward. And you can see also, and Sabina also mentioned about that, you can see on the bottom of the screen, I will try to show with the mouse, but I'm not sure that you can see it correctly. I mean the color. This is you can see the signal. This is a signal of outflow tract, the upper part of outflow tract.
Yes, that's the lowest line on the Carter screen. Yeah, it's in red.
Yes.
It's not a great contrast for us to see, but it's...
Yes, and when I go deep, you can see now there are no signals. So within the pulmonary artery, there are no signals. And actually, this is also one of the topic of discussion regarding the end point of ablation. Maybe we can discuss it later on. But now, for example, you can see, and you can also look to the picture on the left part, the imaging, prepared imaging, and you can see that somewhere the end of the sheath located. Of course, this is a static picture, but for example, if I go back a little bit, you can see a signal here. This is actually I would say, the border of the outflow tract and the beginning of the pulmonary artery. And now this is the main trunk of the pulmonary artery because you do not see any signal here. And actually,
sorry, do you see pocket atrial signals when you're on the floor?
No,
no. Left PA?
No, we don't see atrial signal. Actually, we have in our lab some, let's say, heart specimens, plastinated heart, and maybe if we will have a time, I will show especially this feature, why we have these signals and when to where to put the sheath, I mean, in terms of correct position, in correct position near the bifurcation. So we now...
Alexander, just short question. Can you explain your anticoagulation protocol during those?
Anticoagulation protocol is the following. So all the patients are on warfarin because they have to take these drugs during long life. Regarding this particular patient, so this patient we use 5,000 units of heparin at the beginning of procedure when we put the sheets in, and if the procedure will take more than 1 hour, we will also add 5,000 units of heparin during the case.
And another question is, what is your FEM resolution during this mapping?
Frame?
FEM.
FAM resolution 14, 1.4.
Okay.
I have also two questions. If you would compare, I mean, the catheter looks very stable to me. The sheath is holding it perfectly in place. When you started this, did you ever did it without a long sheath, and how much more movement was there? Or is this just, is that the reason? Now it's nice and quiet, and I could, you know, it's probably going to go in and out a lot if you don't have a sheath, right?
Yes, actually, I mean, we have some experience with the manual procedure, and with the manual procedure, we do not have such stable catheter position and let's say movement during the mapping process. With the sheath, you can see I want to once again underline that the sheath position in such cases, in such patients, are very important. I mean, in terms of stable movement and stable position of the catheter. When we are talking, for example, for the non-steerable sheath, it's also possible. What else? Sabine, maybe I'm not correct. Understand your question.
I just wondered if you know, how much more would the catheter move if you wouldn't have a long sheath in? It would move as much as the Swan guns, or what's the experience?
How long we move the catheter?
No. If you would do this with a magnetic catheter, but without the long sheath in.
Without long sheath. Yes, I mean, I think it will be not. It will be very challenging to manipulate with the magnet catheter without long sheath, because I mean, I think it will be the same story like Swan-Hans catheter that you see, because there were no support for the Swan-Hans catheter, and that is why we had problems. And in this case, you definitely need to have some support. So I think maybe it's not a Picasso picture, but it's close to understanding where we are. So this is a outflow tract you can see here, yes, and this is a right and the left main pulmonary artery. Now I will try to.
I think it's more realistic than Picasso. I like it.
Thank you, Thomas. So I will try to merge it with the CT scan, and we will see what happened. So for the merging with the CT scan, once again, of course, you can do this procedure without CT scan, but I think for beginners, maybe for the first time, it will be useful. So what we will do now, we put the landmark in the CT, scan something here, and try to find the place in the map in the created maps. So attach one, and also somewhere in the outflow tract. So we need only 3 points to do the merge. So now we are making 2, and then maybe somewhere here, yeah.
Okay, so you're using the landmark registration.
Mm-hmm.
Is that something you do regularly? Because I have actually stopped doing this. I just always do it manually.
No.
Try to make my best fit, but this is probably more elegant.
I totally agree with you. So just we do it just for this case, particular for this case, just to see how the procedure can be.
Can I ask a favor before you don't click on it yet? Don't do it yet. Can you show us a big Carter screen? Oh, too late. Okay, sorry. Because I thought it would be nice to see it on a big screen. Anyway, no worries.
So now this is how the map looks like. You can see this almost, let's say, almost merge, maybe not so perfectly, but near to perfectly. So you can see the outflow tract here, and maybe I will do the same. So once again, in the stereotaxis screen, we see the same picture. In the carto screen, we merge it with the CT scan that we prepared before for this patient, and it's merged quite nicely. So we can also play with the transparency of the picture. I will try to do it. So something like that. We can also play with the glass view. We actually use it because you can see the position of your catheter. So and the next step will be the ablation, I think, process. We can create the design line, and we can also discuss about that. So I will create the design line. For example,
sorry, Alexander,
so,
can you zoom into the carto only? Just show us carto only on Odyssey.
No, not the time. So I will try to create the design line.
So it's a bit hard to see because the picture is not so large.
The picture is not so much, yes. So maybe I will design the line and then try to enlarge the picture, okay?
Okay. So this is a cartoon feature I just explained to people who are not familiar with this. So he's trying to make a design line, which then will be walked over to the stereotaxis system as well. Now we see it. Perfect. That's what I wanted. Perfect. Thank you.
Okay. So now I think I will remove
Let's make it harder to make a nice design line. Exactly.
And you can see the line how it looks like, but I cannot, I think, enclose it. I close it, yes, apply, and it looks something like this. I will also can transfer it to the X-ray. We will show in a minute how it looks like in the X-ray, and also so the line for ablation will be also in the 2-3 millimeters just before the bifurcation of the main pulmonary artery to the left and to the right. Here you can see this line.
That's pretty close to the bifurcation, right? So you're not far into the right or left. Is that important? How deep you go?
Yes, it's pretty close, because I mean, based on the previous work and based on the animal study, the main plexus allocated somewhere in these regions, and that is why we perform these lines, let's say 3 circles, just after the bifurcation, maybe 5-6 millimeters after the bifurcation. And this is actually our design line for this procedure. So we are actually ready to perform the ablation. So
maybe you can zoom out with it again to show the rest of the screens.
So more zoom?
No, less zoom, I think, so we can see what the rest of
zoom. Yes, I will, maybe.
And which line do you start with? With the main one, or?
Yes, I will start with the main line. So the line just let's say bifurcation line, and then switch to the left and to the left. But actually, I think it doesn't make a big sense in which line you start.
Okay. So there are a couple of questions here before we start, maybe. There is one question: is how do you ensure safe distance from the left main coronary artery and left phrenic nerve?
Left main coronary artery and left phrenic nerve. Actually, we do not perform any, let's say, anatomical correction for this or measurements, because in terms of anatomy, I think that the left main coronary artery is quite maybe not too close to this area.
Be much away. Definitely, I agree with that. So if you think about where the aorta is, the aortic root is much lower than the pulmonary artery valve, and you see on the right picture quite nicely how high you are actually in already. So you're just below the bifurcation. So I think anatomically this is probably 2 centimeters away from any coronary ostium per se. But I wonder what you think about the phrenic nerve.
But regarding phrenic nerve, actually, we do not have any problem and any, let's say, even temporary problem with the phrenic nerve injury during this procedure. I mean, during the procedures that we already done. So I think maybe that we use not so high energy for this point. By the way, we will use 25 watts and use around 30 seconds per each application. Of course, the topic how many applications and how many energy you should apply for this procedure is discussable. So we oriented on the let's say studies that were done with our Chinese colleagues, that they use 25 watts and application around 1 minute. So in our practice, we use 25 watts and around 30 to 40 seconds per each application. Regarding the distance, it's also depend. It's topic for discussion, but I think we use maybe I will switch the rule and around maybe 10 millimeters between the dots between each application. So now we started to do the applications. You can see it nicely. I will also enlarge the screen.
Can I ask you something as well? This is very elegant.
Yes.
You were a bit concerned about the clot in the left main PA. Do you check how? I mean, I know that I see that we didn't map very far in, and the defect on the CT scan is also marking where the clot is, right? That's my first question. So if you check that specifically to make sure that you're not going too far with the ablation line towards the clot, are you worried about the line?
Yes, yes, absolutely. So we check the distance on the CT scan to this, let's say, possible thrombolocation. I show you that somewhere here, but in the distance from bifurcation to here, it's around, I think, maybe maybe 2 or 3 centimeters. So we have opportunity to do the applications here, and you can see here that the thrombus possibly started somewhere there, and that is why we will do the line here.
Would that be a reason not to accept the patient for that, if the thrombus would be even more proximal? Is there a point where you say you can't do it, or would you then just do it on the side without clot?
No, we will do in both sides, but if the thrombus was somewhere proximal, actually we do not have such cases, but I mean, it's just my guess. If we will have a thrombi somewhere here near the bifurcation, it's possible, I think, to do only 2 lines, just the bifurcation line and the right main line. So I know that.
Do you follow hemodynamics continuously, or you just do it after the ablation, the remeasurement?
Yes, you can see we, of course, we can see the hemodynamic parameters continuously, but we will do the final measurements in the end.
And can I just say, do you see, at the moment we only see the Catheter screen. So when you ablate, do you see any acute change in the pressure? And how do you navigate around the Swan-Ganz catheter? That's still somewhere there, right? Do you worry where it is, or you just ignore it?
Actually, when we perform ablation, we are, I mean, at the end of the procedure, we will try to put this one-hand catheter to do final measurements, and maybe I will check when I do this line. I will check with the fluoro where this one-hand catheter is. Regarding the changes of the pressure during the ablation, I think of course, we need maybe more tough endpoint, but based on our experience, around maybe 60%, maybe from 60 to 70% of the patients experience decrease of the pulmonary pressure by 10 millimeters mercury. And this changing started when we are, let's say, finish the line, maybe the second line, maybe the line right or left lines. So now we are doing the.
But acutely, is there anything changing acutely at the pressure curve, or is there nothing to compare?
Acutely, you can see now that we can actually. I will ask Konstantin. Maybe he can show you the screen of the measurement. Konstantin, can you show us the screen with the parameters? Additional screen.
Yeah, that's nice.
We have a preset of the, let's say, pulmonary parameter screen, and maybe you can see the changing. So now we have, you can see that the pressure in pulmonary pressure is around 80. So I think 38 it's mean pressure. But we once again have to check this one-hand catheter where the position is.
Yeah. So what I see as well is, I wonder if during energy delivery you would see something like, when we ablated on GPs, we sometimes saw AV node slowing, any kind of bradycardia. Does the patient have more pain, or what's happening? Is there any other survey?
Actually, yes. We, I think maybe in 40% of the cases we saw some vagal reaction, like a bradycardia or coughing, or even pain. The patient experienced more pain during this procedure. And we are now thinking about the study for the HFS to do it high frequency stimulation as an endpoint for the pulmonary denervation procedure. And actually, I think there is a case report published a couple of years ago that they use another navigation system, and they perform HFS, and when they saw the brady reaction, it was a point for ablation. And the patient, also with idiopathic hypertension, the patient experienced very well. I mean, the patient has very good outcome. So the message is that HFS probably can be point for ablation, endpoint for ablation.
So, okay. But we can discuss that later in the kind of case, in the entire review. But I'm very curious about the effects and the kind of by effects. How do you know that this line is? I mean, you just made it pretty much freehand, right? How do you know that this is actually reaching the autonomic nervous system?
Yes, I agree with you. And actually, as for renal, we definitely need tough endpoint. We just, I mean, for this particular case and for the case for neuromodulation, we perform just anatomical ablation. So we know that some I mean, the main clusters of the nerve fibers are located somewhere there, and we perform ablation in expected anatomical area of this ganglia. But of course, we need a big trial for that. But I mean, you know, all the data that published for the patients with pulmonary hypertension, I mean, they are all positive. Of course, there are limitations regarding the patient sample size, regarding the technique, but at least there are positive data.
Alexander, how do you deliver the energy? Continuously by dragging? It's not clear for me how you do that actually.
It's point by point. But
and do you can you explain why you choose this? Why don't you drag, for instance?
I cannot explain you exactly why I do it. So I mean, based on previous published data. So I think, of course, it's possible to do dragging. It's possible to perform the point-by-point ablation. I know that in your lab you use dragging, for example, for patients with atrial fibrillation, but it's also possible to do point-by-point. I mean, in this case, I want to present that. To show that this procedure can be performed. I mean, depend on the center with their, let's say, habits regarding the ablation setup.
Yeah.
So now we are almost finished the bottom line, the, let's say, bifurcation line. I think we need to check a bit fluoro where the catheter is. Yes, this Swan-Hans catheter is, the position of this Swan-Hans catheter is not so good, and we need to check it. Maybe we will, before we switch to the another line, we will try to put the catheter, Swan-Hans catheter, in the same spot.
So, Alexander, I have two questions. My first acute question is: your Agilis has also moved. Are you keeping the Agilis where it is? I mean, it's still very stable. So, you need to move the Agilis as well, or do you leave it there? That's my first question.
Sabina, can you repeat once again, because I'm not
on the
hearing well.
Your Agilis has also moved. So do you keep the Agilis if the Agilis is also down in the RV and no longer in the outflow tract? Is that okay for you? Would you just leave it there and just reposition the Swan guns, or I mean, the catheter is still nice and stable where you are, so it serves its purpose.
Yes, but here it's not LAO projection. It's LAO 6 and cranial 6 degrees. This is a different projection that we use before, and that is why we need to have the same projection area or LAO. So I will finish this line, and then I will try to change the position of the Swan-Hans catheter.
And my second question, Alexander, is with the do you have ablation history on your system? Can you? Because I wonder how much energy is deployed per point. I'm not sure if you have it, that module.
It's there.
You mean an ablation setup for another system?
No. It's the I can't see it because it's not. Maybe it is. It's there, right? So the ablation index on your stereotaxis 3D map. How much energy? How high are you? What's the number there? I can't see the bar there.
You mean ablation history?
Yeah, exactly.
Ablation history. So yeah, actually, when I saw the webinar of Thomas, and he used around the cutoff around 250 for each point. So in our now regular procedure for FIB ablation, we also try to use at least 250 ablation index cutoff for each application. I think for this particular case, we also reach the 250. So maybe you can enlarge this screen, the big screen. So we have a cutoff of 200, the low one, and another around 500. So this is actually our regular cutoff for this kind of procedure.
Yeah.
So
I'm not sure the audience got that because it's not enlarged. So we're talking about the screen that has the gray map, the yellow vector, and the map catheter. So you see the white line here, and the left upper corner is a kind of a color bar here. Not sure if you can increase that because it's a bit difficult to see your mouse.
Can you,
where the mouse moves at the moment.
Yes, I will ask to increase this picture.
Perfect.
Yes.
Can you just
yes,
say what you just said with the thresholds that you've set there once more?
Yes, actually, this is the ablation history parameter. It corresponds to a bit correspond to ablation index, but it's energy delivered per second. So it's watt per second when you perform the ablation. So as we know from the literature, 220 ablation history parameters approximately correspond, I think, to 8 gram if we're talking about ablation index. So you can see here in this line, this point by point line. You can see the, let's say, orange dots here, which is correspond to ablation history parameters.
Can I comment on it very shortly, because I think it's also important for the audience that they understand that this is not exactly the same as, let's say that in a manual procedures using different kind of parameters characterizing this. And one of the reason is that this is a true three-dimensional representation of the energy delivery per point, but it's not necessarily means that the width of this point corresponds, for instance, what is used in the ablation index using the manual CARTO. So for instance, in my case that you refer to, if I continuously moving, these are very, very small movements. So if it's 250, it means it is watt seconds. So it means something like if you use 30 watts, or if you use 50 watts, then it's 3 seconds. That it sounds relatively short, actually 5, sorry. Mathematics I have to redo, but anyway, so 5 seconds, it sounds relatively short at first if you just hear it, but on the other hand I move continuously, so I have so small steps that approximately 5-6 steps is reaching one spot what you do manually, so that in total that would be in a manual case something like 1000. So that's very important to recognize, and I think in this case it's the same. So this orange spot what we are talking about, the three of us, this ablation history is a true three-dimensional representation of the energy delivered into the tissue. It doesn't show whether it's fully effective or not, although you can set up it in a way that you see this starburst around the catheters. Actually, it's only calculates when you have good contact, but nowadays it's set up also in a way that it calculates also with a suboptimal contact. But anyway, it's a great help. I have one more question. Is it really necessary to do circumferential? I mean, I didn't search very deeply the anatomy literature on this, but it just my very first PhD was in about the autonomic nervous system. It's hard to imagine that all of the ganglia are circumferentially located here. So
no, I mean, yes, Thomas, you're right. The main ganglia are located in this area near the bifurcation and just after the bifurcation. But the nerve fibers are going and covering the main left and right pulmonary artery in this, let's say, circumferential manner. And the main, let's say, clusters of the nerves are located in this area, and that is why we perform circumferential ablation.
That's nice to hear, but then I worry more about the long-term effect, because if you really destroy axons, then it may regenerate in about like 8-9 months, 1 year. Any comments about this?
It's a tough question, very tough. Of course, we know that, for example, we were talking about the left atrium, yes, and we know that we can, for example, reach a rather good anatomical denervation in some patients, in selected patients, let's say. But the long-term success are not so good. It means that you are right that the nerves can be, let's say, restored. And of course, we don't know regarding the long-term effect of this procedure. This is actually a good point, and I don't have a clear, scientifically clear answer on that. So we are switching to the left-sided ablation, the left main artery ablation. You can see here, we are trying to gently perform this procedure based on that the thromba is located somewhere there, and I will try to move the catheter rather gently.
Alexander, can I ask a favor? Can you transfer the second line that you're now attacking as well to the stereotaxis system, so we can see it on the as well?
To the X-ray system.
No. If you just click on the line on Cato and transfer that line as well over to stereotaxis. So if you go to the line design thing again and then just send it over.
I will try, but unfortunately I don't know why it's not active now. To create the design line, it's not active. I don't know why. Maybe it's let's try to do this.
Anyway, if it works, if it doesn't, then don't waste your time.
Okay.
Just send it over, maybe both of them. Yeah.
Okay.
Thank you.
Okay.
So, but now this is the line. You're going for the left line as the next one, or which one is the next?
The next is the left.
Left, okay. And maybe you can go back to if you compare where the Cato put its dots and where the ablation index showed where the dots are, that's kind of a nice kind of correlation, right? So what I quite like is the fact that on the ablation history, you really have very precise dots. So I don't know, you can't see it on this screen. If you go back to the one with the gray background, or maybe show both of them and the Cato system together. It shows that the catheter is very, very stable. That's the point that I'm trying to do. The stereotaxis catheter is very, very stable. You don't have much sliding. You just have a very precise pinpoint, whatever, 3 millimeter lesion probably. And here, of course, on Cato, it's just when the dot was taken in the end is kind of an average point. But on the ablation history, you see where it actually really was. And maybe you can say something to the sparkling tip as well. Are you watching the sparkling tip on the stereotaxis screen, or you're just watching?
Yes, I think. Can we switch to this stereotaxis screen, please? And I will show you yes. Maybe this is you can see the main screen, but maybe can we see just only the stereotaxis screen? Konstantin? No, not this one.
not the cath lab?
Not the cath lab. So we try to position the catheter, the Swan-Hans catheter, to see the measurements. So can we see the screen, the main screen? Yes, and can we see the stereotaxis screen? The gray screen, this one, please. So now I'm trying to reach this, let's say, tricky part somewhere here. You can see that the catheter is a little bit moving faster here because it's a bifurcation part, but it's quite stable here.
So it's a bit hard to see it from here, but on the gray picture next to the two green ones, you see kind of a sparkling kind of arrows around the ablation catheter tip, which it shows that the catheter is supposed to be in good contact. And you see a relatively little movement. And I just wanted to point that out before. If you look to this red dots here on that map, on that gray map, you see that they're very precise and very concise to where the ablation tags on CAR2 are. So the catheter is not moving that much, which is exactly, that was the view. Perfect. So if you look to the old line, to the first line, you see very discrete ablation points. And again, I share a little bit, Thomas, how can I say, not fear, but when you drag, of course, along the line, you can make a bend relatively easily, right? So these points are very precise and very concise apart from each other. So I'm curious about, because I know there are ultrasound catheters where denervation is taken, is used or is performed with, and they make a full ring. So you're doing kind of a dot along the line technique. And I wonder if that makes a difference, if you're shooting a ring or if you're shooting dots along the line with kind of some interlesion distance.
Yes, so I have maybe some question to Sabine and Thomas. Do you use ICE guided for the procedure with the robotic? I mean, ICE support.
No.
No?
I don't know.
Yeah, we do, but not necessary for the procedures, to be honest. In the past, we did all of the procedures when it was left-sided, mainly for transeptal. It is interesting, but for some manual procedures, when the location of the catheter, especially we just recently realized one of the not yet commercially available catheters, positioning in a PV, it's very important to have a good ICE image, but routinely I do the same as Sabine. We don't use it guiding the procedure. By the way, before we forget, there was a question before from the audience, and that's about have you guys seen in the animal models or clinically in the patients any evidence for stenosis at sites of ablation?
No, we don't.
And also not in the animal research.
And also, so based on the literature on the animal data, I did not find any data concerning the stenosis. Just comment from the procedure. Now we're switching to the right pulmonary artery, and you can see, for example, here the ablation history parameters is reaching more than 250, and this corresponds, for example, approximately 25 seconds for each application. So now we put the Swan-Hans catheter, I think, in the same position. It's a little bit moving, but I think it's near the left pulmonary artery. We see the decrease of the pulmonary pressure, but of course, maybe it's not in the correct position. And maybe at the end of when we finished this right line, sorry, so we will try to put the catheter in the same level. So Thomas,
yeah, but I
yeah.
think we saw it at the beginning that even when it was not in the correct position, it was much higher. So I think we have good feelings about it so far. You will end up with pulmonary hypotension.
Yes, yeah. And of course, you can orient it, as I told before, to the pulmonary potentials. And of course, if the position is not so, let's say, correct, but at least you measuring the pressure in the pulmonary artery. I mean, I think maybe it should be not so crucial where your catheter position is. I mean, the Swan-Hans catheter, it can be right or left. The pressure should be, let's say, much or less the same in all parts.
Yeah, exactly.
In the pulmonary, let's say, trunk. So our anesthesiologist tried to added some additional sedation because the patients feel a bit coughing in this area and a bit pain in this area. So they additionally use a fentanyl.
Yeah, probably that's the thing I wouldn't like.
Yeah. Sorry. Is this a dynamic thing? So you give more when it's painful and then you come off again, or how do you manage it?
Yes, when the patient feel pain or maybe I don't know some coughing, we can additionally let's say use a bolus of fentanyl or propofol, just a short bolus to abolish these symptoms. Let's say.
I didn't get how much ablation you did to the left line. I didn't get that yet. Did you finish the left line already, or did you just?
Yes, I will finish it. I have maybe one, let's say, miss area here, but
Yeah.
I cannot reach it. I don't know why, because of close to the bifurcation and maybe due to thrombus location. I don't want to push too much. I once again try to stay with the catheter there, but I don't want to go deeply inside and try to move the catheter inside from the pulmonary artery. Because, you know, for example, for the pulmonary vein isolation, we can do it, so we can go inside the vein and then move back the catheter and perform the application. In this case, I don't want to let's say, put too much the catheter here.
So when you normally we look at signals to tell how stable we are, what's the effect on the burn. You go now by the sparkling tip. What's your kind of, when are you happy to start ablating? By the stability of the tip, or?
You mean when we see a signal here?
No. If you know there is no signal on the map tip, right? So is that correct?
Yeah.
So you go anatomically to your white line, see that the catheter is where you want your dot to be, and then what else do you check before you start delivering RF?
When we start and when to stop?
Yeah, exactly.
Oh, it's another tough question. So we are actually, as I said, perform the anatomical ablation, and we are try to perform ablation with lasting 30-40 seconds. For example, I mean, basically, I'm oriented on the ablation parameters. Now, if we switch to the stereotaxis screen, when I reach the 250 or 300 ablation index parameters, I stop application. And this application corresponds to 25 seconds time or 30-second time at the ablation point. So once again, for the parameter setup, we use a constant energy of 25 watts and the irrigated speed of 10 milliliters per minute. Konstantin, once again, can we switch to the stereotaxis screen, please?
Alexander, in the meantime, I have a really easy question, just for a change. Of course, now it's a lot of explanation, and you tell us wonderful this whole procedure. I think it's very easy to follow. How fast or how quick would be a procedure just without audience, just in a routine, without actually study, if you just want to treat one patient? Normally, what is the duration?
Yes. Honestly, it will take, I think, 1 hour, maybe 1 hour and 20 minutes. I mean, from the beginning till the end, because I mean, it depends on patient to patient how much time we spend to insert this one Hans catheter. But I mean, the part regarding the mapping and the ablation is not so it's not so tough for electrophysiologists. And I think this procedure can be done within 1 hour or 1 hour and 10-20 minutes. Maybe less with your hands and Sabina's hands. So, do you hear me?
I think it's very important to know that it's a quick procedure, despite the fact that we discussed with a lot of things. You can plan still 2 PVIs next to it, or at least 1 per day. So it's not that a full day.
Yeah, sure, absolutely. I think we almost finished the line, and I want to ask Konstantin to show the X-ray image, the big X-ray image. I will a little bit play with that, something like this, just to show you where the catheter and where the Swan Hans catheter is. So you can see, once again, shot fluoro, that the Swan Hans catheter is located just near the ablation catheter, because you can see the inflated balloon. So maybe it's not in the same position that we had before, but of course it will be very challenging for us to put in the same spot. Once again, can we have a main screen? Yes, I will. So, and can you increase the screen with the measurements? And I think Vladimir will do the final measurements for this procedure. And actually, I will try to rotate the map, how the lesion looks like. You will see. I will try to switch to the glass view. You can see in the Carta picture. So we have 3 circles just before the bifurcation. And
Alexander, just sorry that I interrupt you, but actually, I think we discussed this. Maybe Pedra missed it, but he asked about this, whether the 3 lines are all necessary. But I think in the meantime, you explained it very nicely, and so I don't think we have to address that. And Lara made a comment about the impedance, but obviously you are in a vessel, so it's she said that it's quite high.
So I will tell you the impedance now. I am staying on the let's say near the bifurcation, and the impedance is around 160 or 170.
Okay.
This is the impedance. And now we are doing the final measurements, and I hope we will done with this case. And you can see the changing in the pulmonary pressure. Now we have a 67 systolic and I think around 40 mean pulmonary pressure. So the atrial pressure is 122. I mean the systemic one Vladimir performing now 3 consequent measurements. And we will see the final results shortly. Of course, I'm not exactly remember what was the exact pressure before, but I think it was around 80 systolic, or maybe a little bit more, and diastolic was around, and mean was around 47 or 50, something like that. So we have some decrease of the pulmonary pressure, and then this is good news, with the limitation that the position of the Swan-Hans catheter maybe is not so equally perfect, but at least oriented on the curve, it's in the pulmonary trunk.
Alexander, do you see the patients yourself of your other cardiologist colleagues? Can you give us an impression about the clinics after this, the clinical results?
Actually, our clinic is a referral center for the patients who experience thromboembolic events, acute and chronic. And actually, these patients are in our database, and we are, let's say, try to very precisely follow up these patients. So I think the adherence to follow-up is more than 95%. So we have a special program for this. I mean, to invite these patients to the follow-up measurements. Let's say we perform echo, angio, and all things around. So Vladimir, this is the final, I think, measurements. So I think we have peripheral vascular resistance around 1,000, pulmonary vascular resistance before the procedure around 1,046, something like that. Let's see what we will have at the end of the case. Vladimir tried to enter at some magic numbers, and so now we have 473. So can you see it? So the first 1,468 is correspond to arterial part, and for the pulmonary part, the peripheral vascular resistance is dropped twice, I think. Of course, once again, for us, it's very good and optimistic results, but once again, we 100% cannot be sure that the Swan-Hans catheter is in the same spot, but at least based on the curve, it's located in the pulmonary artery, and you can see it also online. The curve corresponds to the pulmonary artery, and the cardiac output is 4.9 liters per minute.
I think it's quite convincing, to be honest.
What's the effect of sedation here? Is that
effect of sedation? Yes, Vladimir, is it possible that sedation have an impact for this? Yes, Vladimir said that probably the pain can increase the sympathetic tonus, and cardiac output can also be increased. But we have only, let's say, patient symptoms related of coughing and some pain when we perform ablation here. When we perform ablation in the right pulmonary artery, so in the anterior part, only in this part we have a patient system. So I think this is a final view, and with some limitation, I think we have a good results. What do you think?
It's really nice. Can I just ask, I didn't pay attention before. The saturation, the general saturation is 82 now. Was that always around 82, or was there any change during the procedure?
The saturation is now, it was 84, 86, it's now 84, but I think it's it's some, let's say, now it's 83, it's changing. I think it's the same. I don't think that the saturation should increase so acutely. And actually, based on our experience, we saw improvement and stable improvement after 1 month of the procedure, based on echo data, because all the patients in the follow-up in our clinic, we performed the angio 3, 6, and 12 months after this procedure, so 3 times to check the changes in the pulmonary circulation parameters.
And how many times you saw from the, let's say, the above 30 cases, then that acutely you didn't have any effect?
Actually, as I said, we see the acute effect, I think maybe in 60–70% of cases. But honestly, first point, we do not have a strong follow-up data. And the second one, the acute effect, not in 100% correspond to long-term effect, and vice versa. So this is point that can and should be studied more.
That's for sure.
That's for sure. Okay, so I think we need to prepare to the next case, and I think have a break for 20 minutes.
So welcome back. I think we had an exciting morning. We will soon start with the second case. And I think we saw already, for the people who joined us in the morning, the kind of teamwork that the anesthetist who was in the room, the entire team having a constant pulmonary artery pressure most of the time. One time the catheter dislodged slightly, but it didn't make that much of a difference. And you saw the relatively ease of the procedure. And I'm very happy and very proud of the team to change from one patient to the next so quickly. And that's always the kind of Formula One race position where every hands on deck are moving the patient and getting the next one started. So I'm very grateful for the team to make that switch so quickly. Now, I think we have some time afterwards for the discussion. So I think we can keep some of those discussion points. I think overall we've seen a very interesting case. Alexander, are you ready to present this new patient? Are you?
Yes, I'm ready to present the patient.
Fantastic. So let's kick that off. Okay, thank you.
Okay. So once again, good morning, good day. We continue with the second case, and I hope you see the slides with the patient data. So this is a 69-year-old gentleman with complaints of dyspnea during daily physical activity, and as the first one, also with complaints on fatigue and weakness. So he had a myocardial infarction in 2014 with a PCI of right coronary artery. And actually, at that time, the symptoms of acute pulmonary embolism started. And then the disease became chronic form, and he developed chronic thromboembolic hypertension. He underwent balloon pulmonary angioplasty of pulmonary artery branches in 2018 and 2019, but without significant effect. So balloon pulmonary angioplasty means that there are no stenting in the balloon. It's only dilatation of the branches of the pulmonary arteries. So in admission to our clinic, he has third NIHA functional class. Based on echo, he has systolic pulmonary artery pressure of 72 mercury with a mean pulmonary artery pressure of 38. Based on angio, the data equal is the same with the systolic pulmonary pressure of 77 and the mean pulmonary pressure of 40. The peripheral pulmonary vascular resistance parameter is 540, is a little less than in previous patient, because the patient did not have significant improvement of the treatment therapy, medical treatment therapy, because medical therapy included sildenafil, the first, let's say, step, and the Resigot is the second one, and also there were no significant effects of balloon pulmonary angioplasty. So the patient has a residual pulmonary hypertension. Also, he has atrial hypertension and pulmonary artery and peripheral artery disease as concomitant diseases. So medical therapy included Rehabilitation, which was administered 4 months ago, and heart failure therapy and warfarin is anticoagulation therapy. Next slide, please. And this is, you can see the angio of this patient. In the left part of the slide, you can see the angio of the main and the right main trunk, pulmonary trunk, and the right pulmonary artery, and for the right part, you can see the left pulmonary artery. Also, you can recognize some, let's say, some problem with peripheral pulmonary circulation. So next slide, please. So we also performed the CT scan in this patient, and you can see it nicely, rather long right ventricular outflow trunk, and the pulmonary left and right pulmonary artery seems rather, let's say, normal. I mean, in terms of anatomy, of course, they are dilated. But comparing with the previous case, there are no thrombi in this in the main pulmonary artery branches. So now, can we switch to the main screen, please? Yes, you can see it, and we try to be hurry but safety, but we almost perform the, let's say, first step of the procedure, and now I will try to ask to increase the fluoro screen. The fluoro screen now, big one, yes. Yes, you can see it. So once again, I will comment on, we put this one-hand catheter into the right pulmonary artery, and it looks very nicely here. And it's quite stable comparing with the previous case. And you can see also nicely the position of the Agilis sheath, and we also inserted the ablation catheter. And now we plan to do the measurements of the pulmonary circulation parameters, and our anesthesiologist Vladimir will comment on. And Konstantin, can you switch on the microphone of Vladimir, and he will comment on pulmonary parameters. And we also need to switch to another screen with the pulmonary parameters.
Short question before Vladimir gets the word. Indeed, it's very obvious to see the difference between the two stability of the positions. I just wonder which is more typical, the difficulty in the morning or this one, which is relatively stable?
Difficult in the morning, definitely.
So that's more typical what we saw in the morning.
I mean, it's more difficult, yes, what we saw in the morning, yeah. But
I understand, but which represents the more the routine what you have? So which type of patients you see mostly the difficult ones, or this one? What is?
No. I mean, this one, because of course we don't know the end of the story yet, but based on the anatomy and based on how the first step of the procedure was happened, I mean, we don't have any difficulties. So I think this is the most typical case, and we try to do it in our, let's say, regular manner. So can we enlarge the screen with the measurements? And Vladimir will do the measurements. Can you switch on the microphone of Vladimir, please? And now you can see the screen from our main screen from our pre-operating room. We perform the short, let's say, short image just to see the position of the catheter. So you can see this image on the left part of the screen, just to orient it where the catheter is. So this is area projection, and this is LEO. So Konstantin, can you increase the screen with the measurements? We need to have the screen as the main screen to make it big one, please.
Я не понял сейчас.
С измерениями экран увеличьте, который вот в середине. Okay, sorry, we switched to Russian, and I just explained that we need. Yes, exactly. So Vladimir, so in this case, we have a stable Swan Hans catheter position, and I hope we will, I mean, take it in the same place, leave it in the same place as before the procedure, and we're ready to do the measurement.
Hello.
Yes, we hear you, Vladimir.
Hello, hello. Do you hear me?
Yes, we do.
Okay, thank you. This patient, as you see, has a more higher levels of saturation at baseline, but the pulmonary pressure is also high. So we start to measure the cardiac output in this case. You see the changes on monitor. Now we infuse 10 millimeters of cold saline. And wait for calculation. Usually we do 3 measurements to take a medium calculation.
Vladimir, can you just confirm you're doing the same kind of sedation, so the patient is under propofol and some fentanyl?
Yes, the same sedation, the infusion of propofol and boluses of fentanyl, about 2-3 microgram per kilo. But it depends on patient status of, we need to balance between oxygenation and level of anesthesia. Okay.
And the Swan guns is a jugular, right jugular access? Or?
Yes, the same approach. We are jugular vein under the ultrasound guidance. It's a gold standard. So now you see the second measurement of cardiac output. And I think we can take these parameters to make the final calculation. We save the probe. The pulmonary wedge pressure we measured before, it is about 15. We put the data. And the CVP pressure is 6. It was also calculated before. So let's perform a final calculation. And what we see? We see the pulmonary vascular resistance is about 500, 481, and the systemic vascular resistance is around 1000. The cardiac output is much more higher than in previous patient, and it is about 6 liters per minute.
But actually, from my point of view, I cannot, I don't exactly understand the data of cardiac output, because I think it's more variable data. It can depend on.
It can depend on different
other factors,
yes.
different factors,
Yes.
let's say.
So we can make one more calculation of cardiac output to feel
yes.
the difference, maybe.
Yes, let's do it. And during another measurements, can we switch to the main screen, and I will show you the main big screen from the our lab. Yes, we almost prepared all the things, and you can see here that we are ready to register the catheter. So we register the catheter, and we have once again 2 imaging fluora on the left side. It just to orientate it where our catheter is. So this is the LAO projection, and this is the area. So I will orient it on this screen, and we'll also see an area and LAO projection of the Swan Hans catheter.
Alexander, I have a short question. Of course, we are aware of this beautiful publication you in Jack, and can you just tell to us and the audience what were the inclusion criteria for the study? And it's just an interesting question from my side. You had any patients which actually on the table showed different measurements that you expected?
So I will divide the answer into 2 parts. So for our study, which was published in JACC, so we use only patients with residual pulmonary hypertension and patients who underwent open heart surgery procedures, so pulmonary and arterectomy. And inclusion criteria were the mean pulmonary artery pressure more than 25 millimeters mercury, the mean pulmonary artery pressure based on right heart catheterization, or peripheral vascular resistance more than 400. So we finished the study, and now we perform let's say our clinical registry for the different patients cohort. The main inclusion criteria approximately the same, with a mean pulmonary pressure more than 25 mercury, and PVR more than 400. But in this, let's say, observational prospective registry, we included patients with different, let's say, etiology of pulmonary hypertension. Basically, this is a 3 group. This is idiopathic pulmonary hypertension, like a first case today. The second one is the residual patients, but residual also with not after open heart surgery procedure, but also with after balloon pulmonary angioplasty. So if based on the guidelines for pulmonary hypertension, the patients who are not, let's say, respond to any therapy. It can be open heart surgery or interventional procedures like BPA. So the hypertension can call resistance. So we are now collecting, let's say, different subgroup of patients, because an idea, the basic idea how this therapy works, it should be, for our opinion, can be the same for all subgroup of patients. So now we are trying to do, let's say, two things. First, we are trying to once again receive respiration gating and perform the measurements, once again, the measurements of the pulmonary circulation, but you can see based on the yellow curve that the systolic pulmonary artery pressure is around 99, so it's ranged from 90 to 100 mercury with a mean of 53. So now we are asking the patient to breathe, just to have a respirating gating in place. Sometimes it's rather difficult, but we started to do it. So we are now, I put the catheter to the right ventricle, and maybe I will, so we are now okay with the respiration gating, and actually we are ready to start to perform the map. And you can see based on CT scan, I rotated from the right side, the outflow track looks rather long and without any, let's say, possible obstruction in the main pulmonary artery branch. So I start FAM, and you can also see on the left screen on the X-ray position. Can we switch to the stereotaxis screen, please, Konstantin? And maybe you already done it. Great. So we also try to create the right pulmonary artery. So in this particular case, fortunately, there are no thrombi in the let's say main pulmonary arteries, and so we can continue the mapping. So we have sometimes some technical things when the system cannot recognize the catheter, but it can be resolved easily. So the let's say tactic of our procedure will be equal to the previous one. We will create the anatomy and then perform the ablation in the 3 circles. So now you can see when the catheter is, you can see the black circle in the catheter. If the circle are black, it means that the catheter is inside the Argyll sheath. So now I'm trying to reconstruct the outflow tract. As you see, once again, in CT is quite big. It's quite long, but I think we can also manage it. So can we also maybe enlarge the Carto screen? Konstantin, switch to the Carto screen. Okay, great, thank you. Что-то не видит. Maybe any additional comments from the audience, or maybe a question?
So far, I don't see any questions.
Mm-hmm.
And I look regularly the names of the attendees, and it's pretty similar to the morning one. So I think it's pretty clear. So just go ahead.
Okay.
And it's fascinating to see the difference between the two procedures actually, and this goes extremely smooth so far. It's not that the other one didn't go well, but I mean, it went very well, but it's very easy to see. I think it's a very lucky day on a way that we see two completely different patients.
Yes, but I mean, the two completely different patients, but the procedure is quite, I mean, the same. So we have, you can see we have some issue, I think, with the mapping, because we need, I think, to register it once again, because the dots are not cover the area where the catheter is, and we need a little bit to play with the tube, because you see that I cannot collect the point, because we will use fluoro, because I need the dot should be a little bit up.
Yeah, that was one of the questions in the morning, whether you have to raise it, and then you said it's not always necessary, but you see that in some patients it is important.
Yeah, I agree with that, but of course you can manually change it. Just 1 second, we will try to fix it. So we need to play with the tube. Just 1 second.
So, and of course, I think many of us having now an itching fingers to do this. Can you inform us about the post-ablation days? How is it going in the follow-up protocol?
What
Not
do
the
you mean?
long-term follow-up that you explained in the morning, but just the few days after the ablation. And what is the major experience? Do they experience some chest pain after that?
Yes, they experience sometimes chest pain, just like we see after the regular catheter ablation, some pain in the right side. So, but it's resolved very, let's say, very fast, just after 2 or 3 days. Our let's say setting for the medication, so we don't use a specific another specific medication. The patients receive the therapy, and actually not any additional options for manage the patient in the let's say early follow-up. So we need to once again register the system. Because we a little bit move the plane of the projection.
Can you show us a big screen so we can follow what you're doing?
Yes, just 1 second. Konstantin, can we see the main big screen?
Alexander, and then we have a question in the meantime from Pedra. Why did you choose pulmonary hypertension, so the CTEPH patients?
You mean
the thromboembolic type. Why did you choose them?
You mean particular this one?
Yes, I suppose those were available, but That's the question of PEDRAM.
Actually, I mean, because this patient do not have any other options for the treatment, because the medical therapy is not, let's say, I mean, the medical therapy is not effective. The surgery also, in some patients we cannot perform surgery, but even if after surgery, after the pulmonary endarterectomy, so 30% of the patients experience residual. And regarding idiopathic, the same story. So actually this is no option patient. In Russia, I mean, it's very difficult to have stable medical therapy with Resiguat, and not many patients receive this kind of therapy. But in our, let's say, group of patients, we include patients who failed modern medical therapy with Resiguat. So we are now trying to find a good spot for registered, because I can reach the right pulmonary artery, but I cannot reach the left one because we have some issue here, and I will try to register it once again. So you can see the screen. We try to find the dots, because I mean this one of the dots is outside of the screen. Any comments from your side?
No comments. It's a question from Pete, who obviously woke up. So welcome. He's our president of this society. And I think we discussed this, to be honest, but maybe just repeating. What is the experience with another etiology, pulmonary arterial hypertension patients?
And I mean, you mean our experience, yes?
He asked actually specifically, is there any planned broader research for those patients?
Yes, I think yes. Now, of course, it's not so common patients, and we need to collect it. And actually, in our site, we are trying to collect, at least in observational manner, this category of patient. And we are now collecting this data, but of course, if we will, for example, have opportunity to do the multi-center study in a particular category of patient, it will be very interesting to see it. But of course, once again,
maybe you can repeat that in your registry, the current registry, there are multiple etiologies actually. So it's not only
multiple etiology, but the most common etiology is the patients with the let's say tension. We just only started to collect the data in patient with idiopathic. So I think in our registry it's maybe 5-6 such cases. But based on the Chinese experience from Chinese group, they have a very, let's say, optimistic data. And actually, in one of the studies, they also published, they include many different type of pulmonary hypertension, and the result was quite good, and the same like for idiopathic that they published originally. So I think this technology, when the other technology cannot be work, I mean the other treatment option cannot be work well, this technology, in terms of, once again, clinical a small clinical and pilot clinical study showed optimistic results, let's say. So now we try to how to say it, fighting with a good projection. I cannot reach this area because one of the dot which in the, let's say, registration cannot be perfectly set up, and I cannot maybe reach the area of let's say bifurcation, but I easily can reach the area of the main left and right pulmonary artery. So,
although it starts to look exactly like the CT, so it's very close by.
Yeah.
I wonder, Alexander, I wonder, you have still your CT scan kind of separate altogether, not merged. Why are you merging at the very end? If you take it as a roadmap to kind of guide you in the beginning,
yes,
would that not make it easier for you to understand where you still have to go and where's the unfilled geometry?
Yes, Sabina, it's a great point. I think it's, let's say for me, it's like the only point is that we try to do it faster and we are online, and that is why I absolutely agree that the CT scan in this particular situation need to be merged at the beginning, and that is why you can easily manage the anatomy. So I will try to merge it now with the CT scan. Just a bit rotate. So can we have a carto screen as the main? Konstantin, please. Thank you. So let's try to find the first landmark. I will put it somewhere here.
This landmark registration worked pretty well in the previous one, I think.
Yeah.
Yeah, maybe you should explain that. So for all the non-CARTO users, you can put 3 landmark markers down, and actually you can start with a single one, but you could the 3 you have a more precision, and you have to touch them on the scan on one side and then on the thumb as well, and then with the alignment you'll see how it kind of jumps over and puts it in the best position. Now, of course, that's always a little bit of a guess, and especially in a situation like here where you have kind of an incomplete thumb. It's hard to guess exactly where these things are. So now we have 3, and Alexander is attaching the last third landmark. And then on the left-hand thing, this exactly 3 flags, and then it jumps together. And then you can touch probably surface registration as well, just to see if it gets a bit better if you go by the surface rather than only the flags.
Yes, and you can see that
not perfect, but it's not bad. It's not you could push it a bit manually, couldn't you?
Yeah, I can try to change the position manually, maybe something like this, and maybe rotate in the another engine, something
push it
like
up a bit. Yeah, like that. Perfect. That looks pretty good.
Yes, it looks pretty good, and actually we can a little bit play with the transparency, and I mean, in this point, we understand where we are, and actually we can start to perform the ablation. So also,
yeah, see, I like it very much to say where you haven't been, and maybe just then having this kind of merge already, see if you can fill in the other space. So I always merge relatively early, knowing that there might be a mistake, and I might need to do it again or adjust it.
So I will remove
Exactly.
the carto, yes, the merge, and then create the line. It looks
Yeah,
rather
so the
small
merge
here,
all
but
design line feature is always a difficult thing to do, right? So
yeah, absolutely.
we'll
So let's
cut it.
close it and apply and switch to the. So Konstantin, can you switch to the stereotaxis screen? We can see the line here.
It has an interesting suggestion that in the future maybe not a bad idea to use the kind of ADAS type of software where the CT segmentation can be imported directly into the stereotaxis navigant to save even some more time.
Well, you can already merge
Yeah.
a CT scan directly on stereotaxis. That's a feature that you don't need to wait for ADAS 3D for. So that is another option you could do here. The problem is the same as usual, is the merge and the alignment.
Konstantin, can you please show the Carto screen? So we're actually ready to do the first application, to do the first line in the near the bifurcation. And actually, can you also switch to the main screen once again, or maybe for the screen with the measurement screen, please? So once again, let's check the pulmonary pressure before the procedure. Konstantin, can you show us the measurement screen as the main screen? Yes. So before starting, so we see that the systolic pulmonary pressure is around 90. So it's a little bit changing from 90 to 95. And the mean pulmonary pressure is around 49. And you can see that the saturation in this patient is 92. It's higher than in the previous one. So we are ready to start the first application with the same settings. Once again, 25 watts. And I will start with the first application. Konstantin, can you switch to the stereotaxis screen, please? So you can see that the application is lasting now 20 seconds. And we now are reaching the ablation history about 200 to 250. I think that the most, let's say, maybe tricky part is this, let's say, bifurcation line. Because of catheter stability. I think the lines which are near the right and left pulmonary aorta, the catheter is quite stable. So now you can see the changing of the ablation history position. So I switch on the catheter ruler. Once again, we don't know exactly how what should be the, let's say, actual distance between the points, but we try to have this distance around 10 millimeters. So you can see this asterisk on the catheter. Once again, in the ablation catheter, it means that the contact is quite good. So we already comment on this point, and we're also reaching 250 with ablation history. So can we, and also you can nicely recognize where the catheter is in terms of LAO and LAO projection. I will switch to LAO. I think just you can see it. Yes. Now where the catheter is. And actually, this is, for me, it's a very nice tool to see the position of the catheter in the oblique projection. Konstantin, maybe you can switch to the Carto screen to see how it looks like in the Carto screen with the CT. Yes. So we'll also.
what you can also do to make the transparency of the
Yeah.
stereotaxis screen a little bit, I mean, to set up more transparency, and then we will see the ablation history better.
Mhm. So now we are doing the same let's say circle line as for the previous case, and you can see, I mean, in this case, the previous one, we put the auxiliary sheath in the right ventricular outflow tract, and the position is quite stable, and we don't need to change the position of the catheter. And once again, in our lab, maybe we have a time at the end of this case for discussion. We have a heart, plastinated heart specimens, and if it will be interesting, I can show you the position of the sheath in the heart specimens, and we can also discuss it. And once again, comment from my side regarding the signs of bradycardia that sometimes happen and how to prevent it, and why actually we put the auxiliary sheath in the right outflow tract, not so high. The point is that if the patients develop bradycardia, you can easily go with the electrode to the right ventricular outflow tract. So just pull it back, and you can pace from the ablation catheter and resolve the bradycardia signs. So no need to have additional catheter for pacing.
Can you, Alexander, can you show us the big screen again so we can observe the...
Yes. Can we see the stereotaxis screen, Konstantin?
Okay, again, that's nice to see the kind of ablation history and the very, very kind of limited ablation dots. And I think Petram asked that question before, and I think this is going to be our constant question about the amount, if the amount of energy deployed correlates with outcome, or in other words, how many points you make along that line, and the 10 millimeter lesion distance, is that, how did that come up? Is that just anecdotal?
Yeah.
Or?
Yes, it's like, I mean, arbitrary, and this is only by, there are no strict data regarding how many points we need to ablate. But for example, I checked how many points we've done, total ablation points in the first case. We've done 42 ablation points for all the circles, 42. And you know, for example, comparing with the renal denervation stuff, there are some data that when you perform more lesions, the effect is better than you perform 2 or 3 applications in the renal arteries. So probably it also can be, let's say, point for discussion, and also probably when we perform like a circling ablation, it can influence to the outcome. But once again, we need to study it.
Mm-hmm.
And now we're almost.
There are 2 comments in the meantime, and then maybe I can just address them or read them. One of them is, I don't think it's particularly related to this procedure, but of course, the question is whether you can do this remotely, and then the remote here means more like on a telerobotic way. So to do this procedure together with underserved remote regions. And I think we all can confirm that technologically it's possible. The legal issues are different in every country, but it was already from the beginning of this, the history of stereotaxis. Many procedures were performed like that. Actually, I performed just a few years ago a PVI from Miami, and the patient was in Rotterdam. So it's possible. So the answer is yes. And there is another question. We also addressed it, but maybe you can confirm again, Alexander, that how long does the rehabilitation take after this procedure? We just discussed it, but maybe just a few words again to make sure that everybody gets the information.
How many what?
How long does the rehabilitation take after? I mean, how many days or how long period?
Rehabilitation. Actually, I think if there are no signs of complication and if there are no, signs of heart failure, so the patient can be discharged based on our clinical settings 2 days after the procedure. So our cardiologists, a bit maybe conservative. They can, the patient can stay during 3 days after procedure, but not more. But theoretically, there are no, some restriction for the patients after the first day of the procedure, so the patient can try to go back to their regular activity.
And you just mentioned complications. Actually, have you seen any major complications during this study?
Major, no. We have one, I think, complication in our study with the vascular access. But in our series, we have also one complication with the vascular access. But I want to tell you a couple of things, couple of tricky things that we are faced on. Actually, last week we've done the patients through the subclavian approach. Subclavian approach can be also applying this category of patient because the patient has cover filter due to deep venous thrombosis, and we try to use femoral approach to put the guide wire, but unfortunately we cannot do it because the obstacle, because the all the veins, main vein, femoral vein, was blocked. There were collateral veins, but the diameter of this vein was were rather small, and we cannot pass through the guide wire or even sheath and through the cover filter. But we've done this procedure through the subclavian approach. Another point is that we sometimes.
Sorry, can I just inject there and say, how did you solve that with the sheath? That you put the Nagilus sheath from the subclavian then, or how did you make the sheath?
Yeah, actually, from the left subclavian approach, it's look quite easy. I mean, the curve is, for example, as you are, it looks like that you are positioning the coronary sinus catheter. For example, in our lab, we are positioning the coronary sinus catheter, diagnostic catheter, even through the right jugular or even through left subclavian vein. So for us, it seems, rather usual procedure, and the curve of the Achilles sheath and the curve of the whole, let's say, assembly looks very good, and there are no problem to perform this procedure through subclavian approach. Regarding some comments through the cover filters, another comment to the cover filter. So we can also perform this procedure and also put the sheath through the cover filter, which are fixed in the inferior vena cava. It's also not a problem. So we also done some couple of cases. So, I mean, in this patient, in any options, you can try to perform this procedure. Even in such, let's say, difficult scenario like cover filter issue or subclavian approach.
There's actually a question from Peter about the use of the design line feature. I mean, Stereotaxis has a feature that you can make the catheter walk along the design line. Have you used this? I mean, this looks like a simple line. Should the system be able to walk along the line and you just hit your ablation foot switch?
Honestly, I don't use this feature because, you know, the stability of the catheter, especially in the high pulmonary pressure, is not so, it can be not so, let's say, good in terms of high pulmonary pressure. And that is why, I mean, in the line where in the main pulmonary lines left or right, it may be it will be, I think, maybe quite challenging to use this feature. But actually, it's my opinion because I don't use it. Maybe Petro can do it. I mean, there are a lot of.
Thomas, would you use a design line for this kind of thing? Is that
actually? I agree with Pete. I think it's probably simple, but last time I used it, it was more than 10 years ago when I used it for ablation. But on the other hand, if we look at it philosophically, it's a very relevant and I think important question, because in a certain moment we have to move forward with the true automation. And that we don't do it yet. I think not many people are using it. Do you use it yourself?
I actually don't know. I also find it more entertaining to walk along the line. That's that's probably my personal thing. I have a question, another kind of technical question as you're ablating. There is a feature that if you click on the ablation line on the on the Stereotaxis screen, that you can have a kind of a linear display about the energy deployed along a given line. Are you looking at that? Are you using this feature? Because I quite like it. If you do linear lesions for arrhythmia, it's kind of nice to see where gaps are.
Yes, absolutely. We also use it. And actually, for example, when you need to close the line, completely close the line, it's a very nice feature. Mm-hmm. I agree with you, yeah. So, I mean, in this case, we almost done. And actually, can we see the measurement screen? We also can see the changing of the pulmonary pressure. It was around 90 before. Konstantin, can we see the screen? Yes, not big screen, measurement screen, Konstantin, with the measurements of the pressure. Yes, so you can see, I think we have around 90 pulmonary systolic, and now it's 73, 75, and the mean is 33. I will do the last application, and we can switch to the main screen, Konstantin, the big main screen. I will show you the position. You can see in the left upper corner the position of the Swan-Hans catheter, yes? So it was before the procedure. I put the pedal, and you can see it's in the same position. Once again, it's moving a bit, but in the same spot. And we can see, I think, the good decrease of the pulmonary pressure. I think we're ready to final measurements. Vladimir, can you do the final measurements, and can you, Konstantin, switch the microphone to Vladimir? So, and before that, please once again switch to the stereotaxis picture, and I will show you how the dots looks like.
So is that my impression, or but I see far more Cato text than I see ablation history text? Is that, or is that not just my personal?
So yes. Now, can we switch to the stereotaxis screen, Konstantin? Just for a moment.
Maybe make it more transparent, then it's easier to see the.
Yeah.
That was my suggestion. On the upper part, you can make it more transparent with that one. This one, yes.
That one, yeah. Okay.
And maybe
Okay.
if you change the lower value of the ablation history to like 50, I think we will see it. Yeah, what you
Yeah, now you see more. Yeah.
So this is how the applications look like. Yeah. So Konstantin.
But again, the results is quite amazing. I think 2 cases in a row. Although we cannot comment on the chronic results yet, but it looks quite convincing. What do you think, Sabine?
Yeah, I think it's acutely very impressive. Can I just ask Alexander, with the positioning, it seems to me like right in the carina between the two right and left pulmonary arteries, that's very difficult to hold the catheter stable. Is that correct? Or
yes.
Is that the most difficult part?
Yes, this is the most difficult part. Sabina, you are correct. I think carina is always difficult part. But I mean, here, yes, you are right. This is the most difficult part to stabilize the catheter. So, Konstantin, can we see the screen for the measurement? So I think we have final measurements. Vladimir, can you comment on?
Yes. You see the third measurement of cardiac output, and it's stable. Now it's 5.2 liters, and now we're ready to make a final calculation of hemodynamics. We put the data again on the calculator.
I think we cardiac output was around 6 liters per minute. Now it's 520, but I think this parameter is not so. I mean, it's rather, let's say, variable. And
it's a very dynamic parameter.
Oh, you see?
But we see the decreasing of pulmonary vascular resistance.
Yes, it's quite impressive. So it was around 400, I think.
Yes, 480.
400 with something, and now it's 277. You can see it?
Yeah, we're improving in our Russian, I think, but I see it. Yeah.
Yeah, it's in Russian, but you can find
in the center of
2,000,
yeah, you see
277 in the same, let's say, level as before. It's the same parameters. And I think we've done with the cases.
Yeah, well done.
Yes, absolutely. And thank you very much. Normally, we should have a short discussion about it. So would be nice if the audience asked the last questions which were not addressed during these 2 wonderful cases. Congratulate. Sabine, a few words. What do you think?
I think, oh, sorry, Alexander.
Yes, please, Sabine. I just want to maybe, during your comments, I will try to prepare the hard specimens, and maybe I will show you some technical issue for this procedure, but please go ahead with the comments and I will continue. We need to switch to another camera.
Yeah, that's fantastic. I think, first of all, we need to thank you, Alexander, and your team for these really two expert displays of the case and how slick it went. It's really, really amazing. I have a kind of a quick procedural question still. This is a Gillis sheath, right? And the patient is fully anticoagulated. What do you do with the puncture sites? You're just taking, you stitch around them, do you give any protamine? You just put them out,
no, we don't use a protamine. We can rather stitching. We are checking the ICT and then stitching. Sometimes when the ICT is higher, I'm not a big fan of the protamine because for me it's not so easy drug, let's say. And we just pressing for a while in the puncture site and that's it. Or making a stitch if the INR is, when the ICT is rather high and we are not sure that we are we fix the issue with just the pressing the puncture site.
Okay, and how long is the bed rest afterwards for the patient?
How what?
The bed rest. How long do you rest them? 6 hours or?
Yes, 6 hours. 6 hours.
Okay.
6 hours. So maybe I can comment. Maybe if you can see the heart specimens.
Yeah, we have sometimes someone who walks past it, but I think now we see the heart.
Yes, and maybe Konstantin will also help us with the Zoom. I will try also to do it. So this is a real heart specimen. It's a plastinated heart. We use it in our lab just to understand the anatomy. This is a cutting in a LAO projection, and I will try to explain what the structure. This is the left atrium. You can see here. Maybe please give me a pen, please. Okay, thank you. This is the left atrium. You can see it. And I will rotate the heart and I will try to explain where the outflow tract is. This is actually the outflow tract. You can see it. This is aorta. And from this view, you can see the main trunk, the main pulmonary trunk, and this is the right pulmonary artery and the left is cutting in this area. When we look inside, you can see it here. I will demonstrate it, try to rotate it. Yes, this is a tricuspid valve. And also you can see, can you zoom it, Konstantin, please, once again? This is the actual outflow tract. And you can see here, maybe you don't see it correct, but here it's a muscle site. And this is a dark part, it's muscle fibers. And here it's a pulmonary artery, let's say, valve. So we put the Gillis sheath just in the beneath the pulmonary artery valve, just to have a space for the manipulation. From the other hand, and for example, in case of bradycardia, I can easily go back with the catheter and perform pacing from the right ventricular outflow tract when we have a capture, because in the muscle side we will have a capture. So this is what
it's also nice to see the left main there, just for the anatomical question that there was at the beginning of the session.
Yes, I will try to find the main.
I think you just had it when you put it. The part that you just showed us, you could see the left main.
Yes, but for example, we performed the ablation, as Sabina mentioned, in the upper. It's more high ablation part near the main left located. For example, this
If you
is
show us
just
the opposite view, I think we can see it already much better. Then we'll be able to show the distance.
but I will try to show you the aorta and the pulmonary trunk. So actually, aorta is located beneath the pulmonary artery valve, right, a little bit beneath. So we perform ablation under pulmonary valve. So we perform the circle somewhere here. So it's almost impossible to damage left main. So actually, this is what I want to show you from our heart specimens, because sometimes in the difficult scenario, it's rather important to see what you are doing. Konstantin, can you, I don't know, switch to the main screen? But we are now almost finished the procedure. I think we trying to be...
This is the door out, so it's a very nice way.
Very nice view. So I will try to play with the chair, and I will sit over there, maybe somewhere like this. So in this lab, we have, let's say, our special internal rules, because this lab is located in the same floor where the some open heart surgery labs are located, and that is why we need to be, let's say, fully equipped.
Looks very good.
Yeah, and actually, I think I will also thanks to my team, because for second case we tried to be from one hand rather fast, safe, but from other hand rather safety, and I think we've done it in a good manner. I think this is a promising technology that can be definitely tested in the multi-center setting, in the multi-center trial with a big number of patients. But of course, with this technology, I mean with the robotic technology with stereotaxis, you saw that this procedure can be performed rather fast, and I mean there are a lot of advantages comparing with the manual procedure, because you can manipulate easily, and the position of the catheter is quite stable when you perform the mapping and ablation. And I think we definitely need further studies, and I know that maybe some physician who has this technology in their lab and who have this type of patient, maybe we can also, let's say, be together and try to find the room for the new study. And of course, there are some open rooms for discussion for the protocol of ablation, for the protocol of sedation, and for the endpoint. But for example, for the sedation protocol, we use, as Vladimir said, the, let's say, constant stable protocol for all patients in whom we perform such kind of procedure. So we need to fix some issues, but I think we can try to, let's say, better involve this technology in the treatment of the different category of patients, and the patients with pulmonary hypertension who have no other option of treatment can be the same category for such, let's say, novel and optimistic treatment. This is maybe my final conclusion from my side.
Let's push you a little bit longer, since I think we have another 5 minutes at least for this. Can you just summarize the clinical experience, or what's the clinical follow-up for those patients? I think we saw the technical part is very nice. How soon do patients feel better? Can you go back to different dosages of medication for the pulmonary hypertension? Is there, I think you showed in the paper, a very impressive improvement in the 6 minutes walk test. What's the outcome? How are these patients, let's say after a year or maybe longer? Do you know how long is the longest follow-up you have?
Yes, actually, Sabina, it's a very interesting question, and unfortunately I cannot tell you exactly the data, but from my side I'm waiting this data because I think that the median follow-up of our cohort that we published last year is now close maybe to 18 months or to 5 years. The good thing for me that the person who performed the assessment of the all clinical parameters and all follow-up parameters are blinded to the initial results, and I mean, we are not perform any pressure for them to do such follow-up measurements, and also very important that the physician who initially perform the right heart catheterization and the echo parameters, these physicians also doing the follow-up. And I think this is a very important point. But so far, I cannot tell you exactly the result. I expect it. I believe that the result will be the same that we received during 1 year. But of course, we need to have long-term follow-up, at least 3 or 5 years. Regarding the medical therapy, it's also a very interesting point. You know, for example, for Resigoat, there are several dosages how to manage this patient. In this particular case, the patient's taking the higher dosage, so 2.5 milligrams 3 times per day. I mean, these two cases that we presented, and I think in these particular cases we will see regarding the changing of the pulmonary pressure and the result and the changing in systemic pressure. Of course, for this patient, as I mentioned, we will have, I think, the initial follow-up after 1 month. We also have a data regarding 6 minutes walking test, but I not presented in clinical cases, but it corresponds to third functional New York Heart Association functional class. So we're waiting the result, and once again, many data are under analyzing, including hospitalization and including echo parameters and let's say crossover to medication or crossover to ablation therapy. And also from my side, there are also some opening rooms. For example, do we need to have a redo procedure for such patients? For example, if the patients, let's imagine, experience improvement during 6 months or 1 year follow-up, and after that the results became worse, can we do the procedure again? So this is also an open question. So a lot of open rooms for discussion, and we are waiting long-term follow-up data. Definitely, we need it. We need it to confirm it.
Yeah, I think it all shows what you have stressed is that the collaboration amongst the pulmonary hypertension team, the ablation team, as ablationists, they need to be very close in these patients. They are kind of high-end patients, and they need to, you know, it's a team approach for sure. And it's nice to see the patient being rolled out and being fine. That's a great, I think it's a kind of really nice closing thing. So I give back to Tamas. I think you have the closing remarks, Tamas.
Yes, thank you very much. And again, thanks for the whole team. It was a wonderful demonstration of this. And I think we both very happy that we chose this topic. And it was a fantastic, convincing presentation. And as a masterclass organizing committee, we must say we have still very interesting things are coming, including zero fluoroscopy time ablations, probably some congenital ablations we will see. And the next one you guys can expect somewhere at the end of May. So we are working on it with Sabine to find the best topics for the future. And thanks again for everybody, and also for Marluz and Petra for the fantastic organization, and your technical team as well, Alexander.
Thank you very much, Tamar, Sabine, and all Stereotaxis and Robotics Society team. Thank you very much for this opportunity, and we are looking forward to continue our unique robotic procedures in the different category of patients. And
hope to see you physically in Boston, all of you.
Yes, yes, and hope to see you soon. Personally.
Thank you.
Okay, thank you very much. Have a good day. Have a good rest of the day.
Thank you for participating in the Masterclass 3 Pulmonary Artery Denervation, another very successful edition in the Masterclass series. Thank you to Alexander Romanov and his team from the Meshalkin National Medical Research Center from Novosibirsk, Russia, who shared with us 2 very interesting procedures. It was a privilege to follow you over your shoulder today. Thank you to our chairpersons, Professor Sabine Ernst from the Royal Brompton Hospital in London and Dr. Tomas Tsilitarok from the Erasmus Medical Center in Rotterdam, the Netherlands, both organizers of the Masterclass series. Thank you for your very comprehensive discussions. We look forward to welcome you to future masterclasses. For now, I wish you a very pleasant continuation of the day. Goodbye until soon.